Welcome everybody to our July topic call for the NSDPQC. We are so lucky to have Dr. Alane O'Connor with us today. A few of our leadership team physicians had recommended her, and we were lucky enough to be able to align our calendars so we could get her with us today. A little bit about Dr. Alane O'Connor. She is the director of the perinatal addiction medicine at Maine Medical Center and is the medical advisor of the Maine Maternal Opioid Misuse Initiative, a 5-year, $5 million federal grant to expand access to substance use disorder treatment for pregnant and postpartum individuals in Maine. Dr. O'Connor also co-chairs Maine's Opioid Response Clinic Advisory Committee, which advises the governor's opioid response director on clinical and public policy issues. Sorry, I lost my spot. Okay, she has more than 15 years of experience in addiction medicine. Dr. O'Connor lectures regionally and nationally and has trained more than 100 family medicine and obstetric resident physicians. She is a core faculty member of Maine's only addiction medicine fellowship program. And finally, Dr. O'Connor has published numerous peer-reviewed articles on maternal infant outcomes following substance-affected pregnancies, including child welfare implications, as well as the care of pregnant patients with substance use disorders who are incarcerated. So thank you so much, Dr. O'Connor, for being here with us. And I will let you go ahead and start and share your screen.
Great. Great to see you all. Such an awesome turnout. I'm excited to be here to talk to you a little bit about stimulant use disorder, specifically methamphetamines, although I cover cocaine as well, and kind of what we're seeing in the Northeast. I just want to, as my bio illustrates, I'm an addiction medicine provider by training. I am not an obstetrician. I have the privilege of actually working in a setting where we provide integrated care. So it's the largest Maine Mom program in the state, where we have integrated, I'm the addiction treatment provider. We've got OBs, nurse midwives, social work. I've got a nurse care coordinator who keeps the system running. So when I have somebody who comes in, is in a high acuity setting, which I tend to see folks who are sometimes literally right off the street. Sometimes I go see them in the community when they don't come in. We have actually a fair number of encampments for unhoused folks. But I don't do the OB care, so I just want to clarify that piece. I have lots of awesome colleagues who, when there's something happening on the OB side of things, they step up to the plate. So I'm grateful for that. So I'm going to bring up my slides. So we're going to talk a little bit about stimulant use disorder and pregnancy. Again, largely methamphetamine, but I intertwined it here with some. I'm going to move myself here off the screen so I can see what I'm doing. So to also include some cocaine. So I always feel it's hard to start this lecture because this is a super challenging issue, and I just want to kind of say that up front. I think I'm sort of becoming known as the stimulant use disorder person in pregnancy, but I don't ever feel very good at it. So don't worry if you sometimes feel the same. But it's becoming an increasingly frequent problem. So I pulled some recent data from the NIH. We're seeing overdose deaths from stimulants other than cocaine have almost tripled during the 4-year period ending in 2019. The number of people using methamphetamine and cocaine together has increased dramatically. Number of folks with methamphetamine use disorders up dramatically. And then just those who are using methamphetamine frequently, so that's defined as 100 days or more a year, has increased by 66%. So we're just seeing more and more of it. I know all across the country. I did pull some from the Midwest here, and we're seeing there in a large urban sample of individuals with OUD in the Midwest. We saw that 56% had used methamphetamine in the last 6 months, and most had initiated their use of methamphetamine after starting the use of illicit opioids. So I think the other thing to be aware of is that we're really seeing a change in the demographics of folks who are using methamphetamine. So historically, 10, 15 years ago, it was largely sort of white people that were middle-aged. We're now seeing a much larger increase, both in people of color and Black individuals, but also almost a quadrupling in the number of folks who are 18 to 23 using methamphetamines. And that group is actually growing faster than the older population. So certainly we're going to see more of this in our pregnancy or women of childbearing age. Xylazine is also becoming increasingly common. I don't know, I just added that point today. I don't know if folks are seeing it out there, but it's an additive that we're seeing in a lot of the fentanyl in the Northeast, which is actually an animal tranquilizer. And it seems to make the overdose risk with fentanyl, when it's combined with fentanyl, that much higher, but it doesn't respond to naloxone like other things do. So it's just makes an already hard job even harder. And so we're also seeing huge sores. I don't know if folks have actually seen the xylazine sores, but it's wounds that have actually, we had an amputation a couple weeks ago because the wounds were so severe. So, and it's not necessarily just where people inject drugs, it can be all over their body, but they are severe. So we try to have a low threshold, honestly, to admit when we see this really complicated picture. It tends to be easier to admit pregnant patients than those that are not pregnant. So a little bit about stimulant use disorder. Routes of administration vary. So some patients will kind of swallow it, they'll gum it or stick it, inside their mouths. We see folks who are snorting it, who are smoking it, who are using it intravenously. And we also see some sort of vaginal and anal use that tends to be pretty rapid actually in onset, just because it's so vascular in those areas. So the route affects the amount and speed at which it enters the system, not surprisingly. We see a tremendous number of co-occurring mental health disorders with patients with stimulant use disorder. I would say ADHD is probably one of the most common. I think that's in part because folks with substance use disorders, depending on the study you look at, you might see up to a third of folks with substance use disorders also have co-occurring ADHD. So it's a very common co-occurring disorder. The other thing is that sometimes people have almost tried to use stimulants to address, if they've been on a prescribed stimulant and say somebody has taken that away from them because maybe they had illicit substances in their system. You'll sometimes have folks come in and say, the cocaine or the methamphetamine really helps with my ADHD. So that is a pretty common co-occurring disorder. Certainly the rest of the co-occurring disorders that we see, depression, bipolar, anxiety, personality disorders, all those are associated with an increased risk of stimulant use disorder. So at least in the Northeast, a lot of what we see is, it's the contaminated drug supply is probably the best way to put it. So fentanyl itself can induce fatal respiratory depression in only 2 minutes. So what's unfortunately happens sometimes is folks who are actually seeking out stimulants end up getting a batch, so to speak, that is particularly contaminated with fentanyl. So the overdose risk for folks, even if they have sort of a pure a pure stimulant use disorder, always be thinking about the fact that their stimulants could be contaminated with opioids. And so this is a group that's very high risk for overdose. So, even if I have a patient who says, I don't use opiates at all, I give them lots of naloxone just because of that risk of cross-contamination. But it's also important to distinguish whether your patient has kind of passive exposure to stimulants, if you're going to try to treat it, or whether there's really a co-occurring stimulant use disorder. Because sometimes patients will be like, I use stimulants if I'm out partying, or, I might use them occasionally, but I don't feel physically dependent on them. I don't feel like I'm craving them all the time, whereas they might for opioids. Or you might get some people who say, actually, it's the stimulants that are worse for me. Like I crave meth all the time. I want to be using it. The opiates I can kind of do with or without. So just, it's important to kind of tease out which is the primary, or are they both kind of co-primary disorders? So stimulant use disorder, cocaine and methamphetamine disrupt the dopamine neurotransmitter system. So when you think about kind of what happens, it creates this, it hugely increases the amount of available dopamine in the brain. So when I explain this to the residents that I work with, I think about, if you're doing things that you enjoy, that are pleasurable, you go for a bike ride, you read a book, you spend time chasing your dog, whatever it is, you have tiny amounts of dopamine that are secreted into your brain. So I think of it as like a trickle, like you turn the faucet on and there's like a drip, drip, drip type thing. When I think about using particularly methamphetamine, even more so than cocaine, it's like this massive influx of dopamine. So I think about somebody who like basically takes a bucket of, and dumps it in the brain. So it's this huge reward, positive reward, which is incredibly addicting, not surprisingly, because it feels, the first few times people use these substances, they're like, this is the greatest thing ever. I feel fantastic. My mood is, great. I have all this energy, this motivation to do things. The trouble is, very quickly the brain starts adjusting and, isn't secreting any of its own dopamine anymore, and also kind of trying to actively remove the dopamine that's coming in these sort of buckets, so to speak. And also sort of, you can have so much dopamine that you actually tip into this state where people are truly delusional. They have paranoia, they're hallucinating. One of my patients was in the ED last week with a very kind of common picture of too much methamphetamines, hallucinating, agitated, screaming, unable to follow directions. She had actually just been arrested for breaking into a home. And so just doing things that don't make sense because she had had too much methamphetamine. The thing to be aware of is with cocaine, the effects tend to be shorter. So the half-life is, 60 minutes or so, whereas methamphetamine is much longer. So half-life is more like 10 hours. So those symptoms can last for a long period of time. I've actually seen methamphetamine-induced psychosis last for up to 2 weeks. That was in a male patient that I took care of in one of my other settings, but eventually it passed, but he was using or prescribed antipsychotics to deal with that issue, and it did last for several weeks. So as stimulant levels in the brain decrease, dopamine subsides, the pleasurable feelings go away. And again, as I already mentioned, with recurrent use, we see the dopamine stores in the brain are depleted, so leading to depression, exhaustion, of stimulant withdrawal. So when people all of a sudden stop stimulants like cold turkey, and they've been using a lot of it, the depression, the dysphoria, the suicidality that we see is profound. So in the way that you think about like alcohol with physical withdrawal as being dangerous, I really think of stimulant withdrawal as being medically dangerous just because of the suicidality, the depression component. So the physical symptoms won't necessarily be lethal, but the degree to which patients are depressed can absolutely. So these folks can require immediate emergency or psychiatric hospitalization, both on the like too much stimulant side of things and on the too little stimulant side of things. So it can kind of be on both ends of the spectrum. The agitation, the insomnia can kind of be on both ends depending on what's going on with the individual. So not surprisingly, people rapidly develop tolerance to the drug's effects. They use more and more, it leads to continuing impairment, worsening of mental health issues. These folks tend to get sicker really fast. So be somebody who loses their job quickly, maybe loses custody of their children quickly, their social relationships, they may end up, unhoused. As I mentioned, patient who's had no real issues, all of a sudden breaking into someone's home and hallucinating, and she lost custody of her child appropriately. So these are, can have massive implications on individuals. Cravings linger, and then the risk of return to use is high. They're certainly wanting more of that, even with the negative consequences that they're experiencing. The most significant effects tend to be those on the cardiovascular system, certainly also complications of intravenous drug use, as well as the psychotic symptoms that I already mentioned. So we're seeing, significant morbidity in terms of mental health and functional impact, but the major cause of death does continue to be opioid-related overdose. So as I mentioned, these folks are super high risk because they're often exposed to both substances. The other challenge with stimulant use disorder as compared to opioid use disorder is that we have really good treatments for opiate use disorder. I mean, methadone and buprenorphine both work incredibly well. We don't have similar strong treatments for stimulant use disorder, and that can lead to real ambivalence amongst patients because they're feeling like, I know you don't have any good options to treat me, sort of feeling almost stuck. And that, I think, is probably one of the hardest things about treating folks with stimulant use disorder, is that there's no such thing as a quote unquote Suboxone for stimulant use disorder. So for women of childbearing age, this is a huge issue. Certainly long-term stimulant use can lead to menstrual irregularities. So we have patients presenting late. They don't realize they're pregnant. Oftentimes, I had a patient present a couple weeks ago who was, I think 6 months pregnant, and she didn't even look like she was pregnant. So oftentimes small for gestational age infants, and they're very sort of emaciated in general because they're using so many substances, probably not eating well, they're unhoused in many cases. The other thing is contact with the healthcare system is generally limited. When someone's in the throes of a use disorder, whether that's, stimulant or opioid or something else, they're not generally kind of seeking care because there's so many other things going on in their lives. The power structure is real. It certainly complicates women's roads to recoveries. We see a lot of intimate partner violence, transactional sex, sex trafficking. This is a huge issue in our community. Stigma and shame, fear around losing custody of their child if they seek treatment. I think also, again, particularly where there's this feeling of ambivalence that there isn't much to do in terms of treating this disorder. I think sometimes people just don't engage because they don't think there's many options. We don't really know the prevalence during pregnancy. I mean, I've seen numbers all over the board. This seems to be around the most frequent, but about 1%. Pregnancy does seem to increase the risk of cardiovascular toxicity of cocaine. The other thing you often will see is that when people are using a lot of stimulants, they're red and their heart rate's fast and their blood pressure's high, and it can really mimic some of the other things that you might see in pregnancy, like preeclampsia. If you look at the literature, it's pretty clear that stimulant use is associated with preterm birth, low birth weight, small for gestational age, as I already mentioned, head circumference, growth restriction, but it does seem that placental abruption is the most significant risk. Certainly in our setting, typically, placental abruption is, stimulant use until proven otherwise. So really important to try to talk to patients who present with that. If there are any risk factors, maybe get a toxicology screen to understand what's going on. And also certainly an increased risk of transmission of infectious disease to the extent that IV drug use or transactional sex is occurring. There's certainly risk for all kinds of infectious disease for folks with stimulant use disorder. I've read a ton on this topic. It does seem that the connection between any kind of fetal structural abnormalities is not clear, largely due to the presence of confounding variables. So it's hard to know. And I think I study, as she mentioned in my bio, I published a lot on outcomes. And one of the hardest parts is kind of teasing out all the different pieces. So many of my patients are using both stimulants and opioids. Most of them also smoke cigarettes. Many are unhoused. Many have depression. I mean, there's just so many things that might be contributing to adverse pregnancy outcomes that it's hard to say, oh, it's just this or just that. It does appear that exposure to stimulants in terms of stimulant use disorder, so not necessarily like taking prescription ADHD medication, but exposure to excessive amounts of stimulants during pregnancy is associated with difficulty in self-regulation, attention, and inhibitory control in children. And it does look like the neurotoxicity of methamphetamine is worse than that of cocaine, which certainly is the clinical picture that I see pretty much every day. I think one thing that we really advocate for, as those of us who are in addiction treatment, is to really make sure that patients who, sort of the old philosophy to some extent was if you had somebody on buprenorphine or methadone and they're testing positive for stimulants, you sort of just stop their treatment for OUD because there was this perspective that they weren't like engaging enough in treatment or something like that. That's really changed over time, where it's clear, the buprenorphine and the methadone treat the opiate use disorder, but don't treat the stimulant use disorder. And if you stop their, MOUD, their buprenorphine or their methadone, you only sort of double your problem in the sense that they're going to go back to misusing opioids in addition to stimulants. And the risk of, overdose death in the context of that is tremendously high. So we really advocate, continuing to prescribe, if you prescribe buprenorphine, or continuing to, make sure that they're able to access buprenorphine or methadone, really, unless it presents a safety risk, like in other words, they're diverting the medication, they're not taking it. I mean, certainly if I have a patient who comes in and doesn't have the buprenorphine in her system recurrently, this is somebody who I won't continue to prescribe for, but kind of outside the scope of this lecture, but I tend to use the extended release buprenorphine, particularly in the postpartum population, in situations where I'm worried about diversion or just the inability to safely store the medications. Do you mind seeing if there's somebody that could mute? I hear a little bit in the background. I'm not sure where that's coming from. Thanks. It's clear that infants who are exposed to prenatal stimulants or have this prenatal stimulant use disorder should be monitored for withdrawal. So that's one of the most common questions that I get. They still recommend using Eat Sleep Console to monitor for withdrawal, even though that's actually a tool that's designed to monitor for opiate withdrawal. But again, as I already mentioned, a lot of this is co-occurring. So they have stimulants and opioid use disorder that they're exposed to. And sometimes the symptoms are similar. I mean, I think when I think about monitoring infant for withdrawal, it's really about monitoring them for whatever symptoms are the most significant. So it may not be that they have as much in the way of like GI symptoms, but they might have irritability, inability to, suck and swallow, or sort of coordination challenges. So they still need to be monitored appropriately for withdrawal. Breastfeeding absolutely presents a significant exposure risk. I think we've all seen stories. There's a couple cases in the literature in Maine where, that we've actually seen overdose deaths from exposure to particularly methamphetamines in breast milk. And so I think of ongoing stimulant use disorder as being a contraindication to breastfeeding. So it's both the exposure to methamphetamine or stimulants, but also everything else that's going on in their life. I think that's a real question of like, can that person be providing adequate care to the child if there's ongoing significant stimulant use disorder? So I know you all know this, but I think it's worth saying, adverse childhood experiences, I think we're really understanding more and more about that, and particularly as it pertains to the relationship with substance use disorders. And so certainly, this is a really interesting study that I was reading that folks with use disorders tend to have at least one ACE, many have more than that. Women, we see it even more so than with men, and more experiences with emotional and physical abuse, as well as sexual abuse and neglect. That seems to be particularly true, for women again, and emotional and physical abuse and neglect were higher in cocaine users than in other users. So I think it's just, I mentioned this mostly from the context of being aware that there's, treating these patients is really what the Main Mom program does is really care coordination and kind of wraparound services. So oftentimes it's far more than just the stimulant use disorder that needs attention. It's all the social determinants of health and all the other things that patients may have experienced that are contributing factors to their ongoing stimulant use disorder. Just want folks to be aware that we're seeing an increase in overdose, particularly sort of I like this slide because I think it really helpfully captures, particularly, so the part on the right, you'll see kind of where folks are the highest risk for overdose, and it's really that late postpartum period. So one of the things that we've done as part of the Main Mom initiative is that we keep patients in our program. So anyone who's eligible for our treatment program that's pregnant or up to 1 year post-pregnancy. So that can be delivery of a child, or that can be post-termination or post-miscarriage. So we keep folks for up to a year postpartum in this integrated kind of wraparound services program, which is hugely helpful because it really helps monitor for worsening co-occurring disorders, which we often see, as well as just kind of high-risk situations. Oftentimes that was a time when insurance would fall off and other things would happen and patients couldn't necessarily access their medication. So this now keeps them active in their insurance for up to a year postpartum. And then we have a really clear plan to transition their care elsewhere. So hoping to, again, target that risk of overdose, particularly in that late postpartum period. Really just the medication for opiate use disorder is the only factor associated with risk reduction for overdose. And again, key gaps include, mental health disorders, polysubstance use, all the things that you see that present themselves with stimulant use disorder. So all the social determinants of health that need to be addressed, the co-occurring disorders, and everything else to hopefully reduce some of the overdoses that we're seeing. And fentanyl, as I've already mentioned, has only made things worse, and certainly the overdose death risk has gone off the chart because of the fentanyl, and then a co-occurring or the present xylazine as well as stimulants. We're just seeing very, very few death certificates. I see some of the death certificates because of some of the work that I do or the statistics on that. And so often it's multiple substances that are found in the system of folks who have died. So it's very hard, at least in the Northeast where I practice, to get pure anything. Most everything is a contaminated drug supply. So pharmacotherapy, I don't really have a lot of good news for you on this topic. This is like the hardest thing. People say, "Why, I want medication for my stimulant use disorder," and it's like, oh, I wish I could give you some. So none of the medications are FDA approved. There's a bunch of studies, small samples, attrition. These are some of the things that I try, mostly because sometimes I feel like I'm, just throwing things at folks. I think sometimes there's probably a bit of a placebo effect. But I do have pretty good luck with bupropion, which is Wellbutrin for those who are not as familiar with the generic name. I like bupropion because it seems to work for stimulant use disorder. It seems to work for mood disorders. Maybe there's some benefit for nicotine use because in a different formulation as Zyban, it's effective for nicotine reduction. I think the other thing about bupropion is it's an activating antidepressant. So when people stop using illicit substances, they miss the energy that it provided them. As I mentioned earlier, that they sort of had all this energy, this motivation, and the fact that bupropion is a bit of an activating antidepressant seems to help with that. And so I use that. The evidence is up to 300 milligrams daily. I oftentimes go to 450 if it's helping. I really try in every setting as much as I can to use an extended release version. So I almost always use the XL. Start at 150, go to 300, go to 450 if I need to, because that I really try hard with all the things that I give my patients to give them nothing that makes them kind of go up and down. So part of what we're trying to get away from is that feeling that like, oh, I feel bad right this second. I need a drug to take care of it. So I try to use as long-acting formulations as often as I can. Certainly it's not always available. And I do use some things for like breakthrough symptoms, but I certainly try to not use the short-acting bupropion. I almost always use the XL, unless I can't even remember when I didn't use the last XL, when I didn't use XL the last time, unless there was some contraindication to that for some reason. It kept them up all night or something like that. Topiramate does seem to work fairly well for folks. Everything that I've seen, though, says don't use it in pregnancy. And if any of you know better than I do, because you're OB providers, I haven't seen the data suggesting it's not linked to cleft lip and palate. So I personally don't use it during pregnancy. And I'm pretty willing to use most anything during pregnancy for these folks, because in general, anything is better than lots of methamphetamine. So if you can reduce their use or reduce the amount that they're using, the frequency of their use, I think that's a benefit. But again, not something that is shown to necessarily cause complications or deformities or anything like that. Mirtazapine, so that's Remeron, tends to also work pretty well. It's been studied specific to methamphetamine use, and baclofen has been studied specific to cocaine use. I tend to use either. I mean, I don't distinguish kind of, oh, well, you have methamphetamine use disorder, I'm only going to try these meds, or I'm only going to do this med because you have cocaine use disorder. I think of them both as fairly similar disorders. And again, sometimes they're using both, smoking crack and doing methamphetamine. So I will use any medication, oftentimes combination of things. I've had good luck with like bupropion and baclofen. I don't really totally understand why baclofen works, but it has been studied, and patients actually sometimes report that one works really well. The mirtazapine I've used in the higher doses. It does seem to work better for stimulant use disorder. You oftentimes might use it at like 7.5 or 15 if you're trying to address sleep issues. So there is a bit of this like kind of push and shove, or, in terms of which you're trying to manage. The other thing I have seen is that I think, we do see some weight gain with mirtazapine. And oftentimes, one of the biggest challenges with this patient population was when they get into recovery, they oftentimes were very slender when they were actively using substances. And so they really have a lot of trouble with the weight gain that they sometimes see when they're in recovery. And so, which makes them sometimes, I mean, I've literally had a patient a couple weeks ago say, geez, I think about going back to using just because I don't want to be this fat anymore. I mean, that was literally what came out of her mouth. I try not to add anything if I can that's definitely associated with weight gain. So I'm trying to sort of, again, strike a balance between symptom management, but also not wanting to give her another symptom that either makes her feel bad about herself or makes her more likely to go back to using. The whole question of prescription stimulants is like, you could have a lecture on that alone. There are some people who believe that that's better than illicit stimulant use. And I don't necessarily disagree with that. I personally have never used prescription stimulants for the treatment of stimulant use disorder. That said, I have used, I have treated folks who have underlying ADHD with stimulants under the expectation that the use of illicit stimulants does stop. So it's kind of, you could have 5 of us giving the lecture and you'd get 5 different opinions on that topic. That's just where I sit. I don't use it specific for stimulant use disorder, but again, there are people that do that. And I think philosophies are changing because of the lethality of the substance use disorder epidemic. I think sometimes we feel like there's things that you don't want to end up doing, but you feel like you do, because it's like, I often describe my job as like trying to figure out the least bad of many bad choices, like just trying to think what's going to have the least amount of harm, when knowing that most things will have some harm probably. So it's a difficult situation you all find yourself in. Modafinil is not an amphetamine, but it is a sort of low-level stimulant. I've seen that one used a couple times, kind of again, when like nothing else has worked, I think it's reasonable to try. The one thing that I have had good luck with, if patients aren't on an opioid, is actually extended release naltrexone, or you can use the oral version as well. Naltrexone is Vivitrol, for those of you that are not as familiar with this. So that, in combination with extended release bupropion, does seem to actually work pretty well for people with pure stimulant use disorder. The challenge is that you need to not have any opiates on board. So in the setting, I've used this sometimes when people have come out of correctional facilities where there's not access to MOUD, if they have an opiate use disorder, and I'll give them naltrexone with bupropion, and that's actually worked pretty well. I tend to start with the oral and then kind of move to Vivitrol if needed or if desired. Different patients desire different things. The behavioral health interventions for stimulant use disorder, this is by far the most promising thing, contingency management. And so there's more and more out there available about contingency management. So it's truly an evidence-based treatment. So it is the most effective. When you look at the literature, like what is the best treatment for stimulant use disorder? It is contingency management. It provides rewards basically to patients to incentivize either treatment engagement or negative drug screens or anything else. So it's basically rewards. It's kind of reprogramming the brain to respond to other rewards. So competing reinforcement to the brain's reward system has been significantly impaired. The biggest challenge of this is that there's all these sort of federal, sometimes state laws that have annual limits on the amount of patient incentives or whatever you can actually give to the patient to have that be a reward. So there's all this literature about, you need to recognize CM or contingency management as evidence-based treatment rather than financial incentives, because the federal law at this point limits you to $75 annually, as I understand it. Sometimes non-cash rewards are treated differently. So you could have a setting where maybe you give like a diaper bag or baby toys or baby products or something like that. I mean, there are ways in which you can work around that, if I understand, but it's challenging. I have seen contingency management. I went to a lecture recently, which is excellent, on a person who actually set up a contingency management program in her practice. And they rewarded folks for not just appropriate drug screens, because you don't want to sort of motivate people to bring in, other people's urine or things like that, but they rewarded people for just treatment engagement. So if you came to your appointment every week, you got sort of points. And then they had a system where they could use kind of points to get things within, I think the hospital had like a cafeteria or a different sort of product area where they could almost trade these points. They also rewarded folks for engaging in exercise. So there's ways in which you don't necessarily have to do it specific to people not using substances, but the rewards piece of it is the most important component. I have not done this myself, other than there was a digital platform, one of the online CM programs that I was part of a trial of, and that was actually really cool, and patients loved it. They were able to do like basically counseling sessions on their phone, so they would download it onto their phone, and then when they had done a certain number of counseling sessions, they were able to kind of get a reward for that, and they actually got small amounts of Amazon gift cards, was how that particular clinical trial worked. Patients liked it. And there was a recent study written that I was looking at, which showed contingency management. It was just one singular case study where it was a HIV positive pregnant patient who had significant ADHD, and they basically, her situation was she had to go to the pharmacy every day. Whoops, can somebody mute that person? I don't know if I can mute that person. And so she'd go to the pharmacy every day and basically take her stimulant medication for her ADHD in front of the pharmacist. That was a way that they could ensure that that patient was using it appropriately. And then because she was able to kind of stabilize and not use illicit stimulants anymore, she was able to engage in treatment for her HIV. So there's, again, ways in which you can get creative with this. If anybody's thinking about doing this, like setting up their own CM program, I highly recommend the Opioid Response Network. So the ORN, I can send you the link if folks are interested, but they basically provide consulting, and that's what they do. They help support folks. I've given lectures as part of the ORN for other topics, but they can help folks set up a contingency management program if that's of interest. I mean, this is the treatment. And I have a colleague who's actually just launching a pilot CM program, and I'm eager to see how hers goes. She's one of the main mom providers in another part of the state. So I'm eager to see that, but that it is the evidence-based tool. So just what you take away from this lecture, that's critical. CBT also certainly helps. I mean, that there is some evidence to suggest that that is effective, not as effective as CM, but effective. So again, just kind of working with patients to identify, some of the challenges of stimulant use disorder, ways in which they can change their behaviors, understand why they're using. I think a lot of the time, the work that I do with patients is really simple. So it's, motivational interviewing, CBT. I mean, certainly I'm not in any way suggesting I'm a specialist in that. We have counselors who are far better than that at that than I am. But just working with patients who are eager to stop using. Sometimes it's things like, getting rid of your phone, changing your number, making sure that you don't have any of your old contacts, making sure that you don't go to X location where you used to get your stimulants, or you don't see your cousin Tom because Tom is the one who always has the stimulants. So sometimes it really is that simple, kind of working to help people change behaviors on a very basic level. One of the best parts of the Main Mom program for us is peer recovery supports that we have. So we have, I think it's 6 now, but in our program, we have 6 women who are in long-term recovery who had substance use issues during pregnancy, who provide peer supports to our patients. So it's a really beautiful model. I've worked effectively with peer supports in the past and somewhat more ineffectively. This is a beautiful program in that there's a high level of supervision. So there's somebody that oversees the 6 or 7 folks to make sure that they're doing okay, that they're, keeping up appropriate boundaries, that they're making sure that they're sort of practicing peer recovery support as it's supposed to be practiced. And so that is great. The other thing that works really well about this program compared to other ones I've worked in is that we ask a patient, so, hey, would you like to have a peer recovery person contact you? They say yes or no. I put in a referral that then the peer actually contacts the patient. And having that, I can't tell you the degree to which it makes it more successful, having that initial contact go from peer to patient. Because you send a patient home with a card and they're like, either they lose the card or they're like, I don't have the courage. Maybe this person isn't going to be very nice. Versus the peer reaching out and saying, hey, you're Alane at Maine Medical Center said, you would like to work with a peer. And they can do however they wish, like in terms of their relationship. Sometimes patients and peers text back and forth. Sometimes they have Zoom calls. Sometimes they meet for coffee. They can kind of do whatever they want. The other thing is that it's totally confidential from me. So the treatment team only can know, the peer might report back, yeah, hey, I'm working with Tammy, we're actively working together, that kind of thing. But they can't say, oh, and then Tammy told me X, Y, and Z. Like it's a very confidential thing, which I think is really nice because it's just very pure. It keeps it very discreet about sort of who's, kind of what is being said or not said. But the peer certainly, which doesn't mean that like the peer is definitely trying to get the patient to have open and honest conversations with their providers, but they just certainly don't report back to the provider, which I think is just a really nice model. I don't know how much peer support you have out there, but it has been transformational. Now that I've worked with peers for probably 4 or 5 years, I don't know how I practiced without peers before. So it's been great. Certainly, case management is hugely important, as I've already mentioned throughout this lecture, that the social determinants of health are huge. Housing, electricity, transportation is probably by far our biggest challenge because, even though I'm in an urban area, a lot of my patients are in rural areas. And so and I also have practice in corrections 1 day a week, and I work in a very rural setting there, and I see patients post-release from jail, and just getting them back to the jail to get their, medication or their appointments is incredibly challenging because there's not, public transportation really other than in the big cities. And, some of the services that you have to use, you have to give them 72 hours notice and still they cancel. And so in the urban environments, we are able to use, we have Uber Health, which has been super helpful. So we can send kind of Ubers for patients, but in rural areas, that of course is not really a thing. So it's transportation, I would say, is our biggest challenge from a SDOH perspective. So what do you do when you have a patient with stimulant use disorder? Just kind of like, what do I do if I'm, if I'm used out there sort of on the front lines? I mean, screening, brief intervention, referral to treatment is, what you should be thinking of all the time. So SBIRT, I put in a link, I updated it just a couple of days ago to make sure it was the right one. There's a number of really good screening tools that are available. I love evidence-based screening tools, one, because they're evidence-based, so they provide good information, but also because I think people really have a hard time talking about substance use with folks. And I see this every day because I train people. People don't know how to have a conversation. And so just having a screening instrument to kind of start the dialogue can often be super helpful for people. And that gives you good information, and then connecting with the treatment resources in your community. Warm handoffs are definitely better, active referral linkages. So if I have a patient who's more appropriate for methadone for whatever reason, who's in the office, you know, and they don't want to be a buprenorphine, or they've tried to transition and it's getting harder because of the potency of fentanyl, which is kind of off topic, but we can talk about if people are interested. I'll have one of my staff members like sit with a patient in the room, call the methadone clinic together, you know, get an appointment scheduled, make sure that they have transportation to get to that appointment. Because again, if you send a patient home to do that, they may not have a phone that works. They may run out of minutes. I mean, just all those things that are barriers that are all sort of omnipresent, I feel like. So try to do warm handoff as much as possible. As I said, I'll go in the community and see patients if they don't come into the hospital. Sometimes, you know, we'll have you know, outreach workers from the community come in with a patient to bring them in. I mean, really, whatever way in which I can get services to a patient is what I'm happy to do. You know, considering motivational interviewing, like I've already mentioned, guides the patients toward acknowledging the problem, how they might be able to change their behaviors. And then again, peer recovery support, I think hugely important for pregnant people. There's no group that's more discriminated against than pregnant patients with substance use disorders. I mean, people tend to be pretty judgy in general about people with substance use disorders, but like pregnant people with substance use disorders are just like off the charts stigmatized. And so even amongst my patients who are not pregnant, we'll sort of sometimes project stigma toward pregnant patients. Like, well, you know, if I were pregnant, I'd be able to stop using. And it's like, really? Because that's not how it works. So super important to connect them to whatever supports that they're willing to take. And I think just having that friendly voice of somebody who is able to kind of come through their pregnancy and postpartum period, and either retained custody of their children, got custody of their kids back, you know, being able to have that dialogue with somebody who's truly walked in their shoes is hugely helpful. Harm reduction is super important. Again, particularly for folks who are somewhat more ambivalent about treatments. So, you know, really important to talk about how stimulants are laced with opioids, naloxone, make sure patients have access to it. We hand it out in our practice because even though it's covered by our main care, which is our version of Medicaid, you know, again, patients don't pick it up. It's not filled at the pharmacy when they get there. They feel judged when they go to the pharmacy. So basically, I'm like, hey, you want a couple kits to take with you, and you know, give it to your friend. I mean, it's like the only thing I can, you know, give out that I want them to give it to other members of their community. So I tend to give patients who are actively using 2 or 3 kits because again, we see the days of, you know, 2 doses of naloxone reversing an overdose are long gone. It's more like 6, 8, 10 doses of naloxone. So it's important to have lots of it available in the community. Safe injection practices are really important. So syringe exchange programs, we have some that are actually available by mail because again, we're a pretty rural state. And again, that can be, you know, people sometimes feel strongly about syringe exchange programs, but the data is really clear that there's tremendous amount of value in terms of reducing harms. The other thing is that, you know, I used to practice in an area that was very close to a syringe exchange program. And the ability to sort of have like kind of warm handoffs or connect them with treatment is really important. So sometimes people who are more in kind of a harm reduction mindset eventually get to a space where they're like, no, I really want to get into treatment. And so being able to be connected to those resources in your community so that you're a way for folks to get into treatment is important. PrEP, certainly if that's an issue, safer sex practices. And again, sometimes it's really as simple as talking to patients. Like when patients come in and say, well, I'm not going to use it anymore. Okay, great. Like that's awesome. But like, let's talk about what that looks like. You know, do you have drugs in your home? Because if there's drugs in the home, they're probably going to keep using. Did you get rid of your pipes, your syringes, your rigs, whatever it is that they're using? So, you know, that's important. Other things, materials related to substance use, contact with people who deal or use drugs. Again, what I mentioned. Really getting a new phone number is oftentimes like the best intervention that you can tell folks, because, you know, lose your contacts. People who are selling you drugs or using drugs with you are not truly your friends. And so it's important to kind of just totally reboot your life. That being said, I think that's what's hard for people a lot is that they feel like, oh my God, I don't have I don't have any quote unquote friends anymore because everybody that was my friend I was doing drugs with. And I think that's where the peer support piece is really important as well. That's my last slide. Yeah, I have a bazillion resources there. If anybody wants them, I will stop sharing so people can ask questions. Phew, thanks for listening.
Thank you. That was fantastic. We have some time for questions. I did get one in the chat. So what is considered late postpartum timeframe? I think that was referring to that slide with the graphs.
Yeah, great question. So that it basically, I think, was month 9 to 12 postpartum. It was about that time frame. Basically, I think it's sort of the third. So around the last 3 to 4 months is, but less than a year. So thank you for clarifying that.
Perfect. And then if anybody else has questions, you can throw them up in the chat and I can read them. Or if you want to come off of mute, this will be recorded. And if Alane is okay sending me her slides, I will make those available as well.
Sure. Yeah, no, I can definitely send the slides.
Perfect. Thank you. Any other questions? Feel free to come off of mute.
I hope that means it was still interesting to all of you.
It was. You must have just answered everybody's questions.
It's so hard when everything's the black screen with names. So, but.
Yes. All right. Last call for questions before we close this, and you guys can have 10 more minutes of your lunch hour. Lots of good information shared. Thank you. That was from Amy Rader. Anybody else have any questions?
Oh, I just have one question. I don't know, are you seeing some more infants becoming respiratory depressed from the multitude of drugs that moms are receiving for different things? It does seem like then, you know, if they have that respiratory depression, are they given naloxone for any other drugs, just because sometimes then they're needing some oxygen, which then has them go to a NICU baby instead of being with the mother?
Yeah, so I'm definitely not a specialist in pediatrics at all. I think that, you know, it's a good question, and actually one I can ask my neonatal colleagues. I think one thing that there sort of seems to be a bit of a celebration in the sense that with Eat, Sleep, Console versus kind of the old Finnegan scoring system, we see so many fewer infants actually requiring treatment or any kind of extended treatment. I think, you know, when I first started practicing like 15 years ago, we saw a lot more infants started on, you know, methadone for their withdrawal, and then they were in the hospital for like 2 months, and it was always this very long extended period. Now we do a lot more kind of on-demand dosing or kind of PRN dosing. So I think the perspective is that the experience is less severe, but you raise a good question of kind of like, what is that experience like kind of in that shorter window of time? Because, you know, time and severity are not necessarily the same thing. It's a good question. I think the other challenge, of course, that we see, particularly in my clinical practice, more preterm deliveries. And it's also pretty clear that the kind of standard screening and, you know, tools for premature infants is not necessarily, it's not like validated for use in earlier term infants. So they tend to have fewer symptoms in general, probably because we're not measuring them in the way that is appropriate for being a 32-week infant. So it's a good question. I don't know about the respiratory piece, but it's complicated for sure. And I think the social complications probably are as severe as the medical complications at this point.
Thanks.
Anyone else?
Well, thanks for your attention. I super appreciate it. And I will send Morgan a copy of the slides. And you're welcome to share my email if anybody has any ongoing questions. I'd be happy to answer whatever comes up.
Fantastic. Thank you so much, Dr. O'Connor. It was a pleasure having you with us today.
Thanks for having me. Bye.
Bye. Thank you, everybody. Have a great rest of your afternoon. And this recording will be shared and on our website probably by the end of the week or early next week.